So my name is Gal Sela. I'm an owner and senior lecturer for Optimal Dry Needling Solution. We are an international company and teach during pre-corona times about 100 courses a year across Europe, Africa, Arab countries, the United States, and so on. I'm the lecturer who usually handles the Middle East, Israel, and to Europe, while some of my colleagues do the other things. We are not such a small company. We have quite a few assistants around the world, and the goal of what I'd like to do here is not just obviously get you onto our courses, but also explain more than how to stick a needle in and why we stick needles in, but think about how we do these and how this whole thing just joined physical therapy over the last few decades and years. So what is this lecture going to look like? We're going to give a definition of what dry needling is. Then I want to talk about the essential concept, the essential things that you're looking at, what the clinical reasoning is to why we're sticking needles in the patient, the basic science behind the dry needling, some recent clinical research about dry needling, and then we're going to do some questions and answers for you to be able to question. The chat right now is not open, it's not open on my screen. So if you have any questions, you can raise your hand. There's an option of raising the hand that is open on my screen for participants, but I will have specific time for questions as we go along. 1 second. So what is dry needling in general? Why is it called dry needling? Dry needling is sticking a needle, a solid needle, inside a patient. And it's called dry needling as opposed to wet needling, in that in dry needling, you're not actually injecting the patient with any medication. Most of us are physios. There might be some doctors on courses that I teach in some countries that are allowed to inject, but for most part, physiotherapists, physical therapists are not allowed to inject into patients, and therefore we will have to limit ourselves to dry needling. When is this used? 21% of orthopedic clinic visits, no, I'm sorry, what is myofascial pain? I'm sorry. Myofascial pain, pain that comes from the fascia or the muscles. 21% of all orthopedic clinic visits are for this myofascial pain that's non-traumatic. It's an overuse injury, it's a muscular pain, it could be a fascial pain, but it's not I tore this, something specifically happened. 30% of GP visits, of general practitioner visits, are just the pain, it hurts, it's not comfortable, so on. And if we look at pain management clinics, and this is really interesting. Take a look at this. 85 to 93% of patients who are going to pain clinics are there because of a problem that's stemming from their muscles and from their fascia, and not actually stemming from, God forbid, cancer or something inside one of their other parts of their body, one of their hearts, gallbladder, or something like that, which that part of that could be myofascial pain, like menstrual pain, but other pains, they're not. So 85 to 93% of the patients who are going to go to a pain management clinic, and that's a big deal to take your time on and go out and do that, are actually going to be with myofascial dysfunction. So what is a myofascial trigger point? Because that's the thing that we're actually going to stick a needle in. A myofascial trigger point is a highly localized, painful, or sensitive spot almost all of us know about this upper trapezius trigger point, okay? That you can palpate and you'll feel a top band, you'll feel this tightness in the band, in the skeletal muscles, and there will be some pain referred, pain going somewhere else, not just where I'm touching. And that's part of the myofascial pain syndrome. What is a local twitch response? And it's something that I'm going to talk about through the lecture. A local twitch response is a brisk, involuntary dump, contraction of those fibers inside the trigger point, inside the top band. It's not a complete muscle contraction. Not the whole muscle is going to contract. You're going to get just a twitch of those particular fibers, which will give a snapping. You'll be able to feel that in your finger, the top, inside the top band. So what are the essential concepts? What are we thinking about when we have trigger points? So a trigger point is going to be a place where the muscle is actually, or some of the fibers of the muscle are actually contracted. And if they're contracted, they're going to limit my range of motion because our muscle is going to be shorter. They're going to limit my power, my ability to contract, because if part of the muscle is already contracted before I actually do the contraction, then I'm going to test weaker, I'm going to look weaker. They're going to cause pain because if I'm in this circle of having this discomfort all the time, then I will be uncomfortable and I will cause pain locally and somewhere else. And there will be some proprioceptive problems. Now, the proprioceptive problems are going to be secondary to the fact of the other things above. If I have pain, then I'm going to limit my motion. If I'm going to limit my motion, I'm going to lose some of my proprioception. If I'm going to have a loss of power, I'm going to have some problems with contracting the muscle and knowing where the muscle is in space. And if I'm going to have a limited range of motion, then my proprioception is going to be affected. So it's a circular sort of thing that the proprioception is the functional problem that I'm going to find, but we need to go back and look at what's happening for our exercises, because we must retrain the movement. We need to retrain the way the person is acting right after the needling, because once we stick the needle in, once we release them, once we relax this patient needs to start working properly. This patient needs to start understanding that up to that point, they were not moving the best way for them. Notice I didn't say the right way. They're not moving the best way for them. And in that window of opportunity where they're having the power back, they're having full range of motion, they're having less pain, if we move them, their proprioception will improve and their power will improve, and so on. What is myofascial pain syndrome? Nearly 1/3 of patients with musculoskeletal pain disorders will have a myofascial pain syndrome. Now, a syndrome, there's a hypothesis behind this, which is called the integrated hypothesis. It's a hypothesis that was put forward initially by Travell and Simons, okay? But it has been published and talked about again and again and again. The integrated theory is saying that the local myofascial biomechanical problems are going to give us an energy crisis. They're going to give us pressure on the capillaries. And if I'm not going to get any capillaries, then I'm going to have chemical problems. I'm not going to have any oxygen. I won't be able to release the muscle as well. So by having this integrated theory that is saying that if there's no blood flow, then there's going to be a significant reduction of oxygen. If there's a significant reduction of oxygen, then there's no Krebs cycle. If there's no Krebs cycle, then we can't make ATP. If we're not making the ATP, then we can't actually release the actin and myosin, which will cause us to stay tight. And then if we stay tight, calcium will leave our cells and will keep this muscle contracted. And if you look at underneath on the slide, presynaptically, postsynaptically, we have different polarization, then we just sort of get stuck there. We get an abnormal acetylcholine receptor activity, increased activity. We tighten up more and more. We get abnormal muscle spindles working, so they stay tight and and we stay hyper active. So what we're looking at when we're looking for a trigger point is a tight, palpable band, exquisite spot tenderness, patient recognized pain, painful limited full stretch range of motion, and muscle weakness. All of these 5 things are the things that we're going to look for to understand that the problem is from a trigger point. Those are the essential criteria. What is the biological reasoning behind this, okay? So first of all, we have a problem of pain. When all of us have experienced pain, the way we usually react to pain is by limiting motion. We limit motion and we guard the area that we're limiting our motion from. The moment we guard the area that we're limiting our motion from, then we will tighten up and change the tone of that area. So there's 2 different thoughts about this. There's a tissue-based thought that I'm just tightening up and everything tightened up and something's happening on the tissue. And there's also a central thought, and we'll talk about this a little bit. Initially, or the older hypothesis is the integrated hypothesis that I just described. There's a new integrated hypothesis which gives us a little bit more information about maybe some of this problem coming from the upper motor neurons or secondary manifestation of peripheral neuropathies. So what does that mean to us? That means to us that something's going on with the nerve. Okay, something is going on with the nerve, which is sending information to the muscle. And that's telling the muscle, tighten up. Let's be over tight. Overactivity from top down. Now this is important because it is a newer concept that Wolfson published in 2012, but it's not unheard of. There's papers in the 70s and 80s that talked about this as well, but not as in the same format that we deal today. What this is saying to us, and this has nothing to do really with dry needling, sometimes muscle tightness has to do with our brain overactivity, with being tense, and with just having a problem, a neuropathological problem. And we need to make sure that we understand where this is coming from, because otherwise we might be treating the wrong thing, okay? What is the evidence behind the trigger point? Is there evidence showing that the trigger point actually exists? We're presenting this, A, because there is evidence, and B, there are people who say that the evidence is not good enough, and we'd like you to judge for yourself. So Sikdar is a researcher that is using Doppler ultrasound, and he's looking at the blood flow in the active trigger point and in the neighborhood behind that trigger point. So if you look at the picture on the right, you can see that in the trigger point itself, okay, in 2D ultrasound, you can see that there's high resistance to blood flow. So you can see that there's a lot of blood getting stuck on the left side of your picture. And what Sikdar has shown in his papers later on is that during the diastolic heartbeat, when the heart is resting, there is 0 blood flow into the trigger points. That means that 50% of the time, you're not actually getting blood flowing into that trigger point. No blood flow, no oxygen, no Krebs cycle, and we're staying in that circle. In 2011, Raha is looking at detecting the local twitch response of the myofascial trigger point in the lower back muscles. And what he sees is that it is that those muscles are 27% stiffer, they're tighter, okay? And when you do the Doppler ultrasound, again, you're seeing this poor blood flow into the area, okay? So we're having some evidence when we look at the pictures. And if we look at this picture, this is from the Sikdar paper from 2009. You can see the upper trapezius on the top left, and you can see a uniform, healthy upper trapezius with uniform blood flow. And then you can see the upper trapezius in the trigger point. You can see this hypoechoic area where there's less echo coming from. And in the blood flow, you can see no blood actually getting there. Okay, very poor blood flow getting there. Oh, sorry. And what you can see finally is what happens when we increase that blood flow through needling it, through getting a twitch response and needling it. Let's talk a little bit about the electric EMG findings for this, for the trigger point. In 2015, we see that the electrophysical characteristics in the active trigger point are increased to the non-active trigger point. And if you look on the right and you look at A, the dead person, obviously from the movies, B, C, this is not a heart rate, but what you're going to see is that when you stick a needle on the EMG, in the muscle, in the trigger point that actually is active, you're going to have increased spontaneous electrical activity. So the twitch that you're seeing in D and E, in the muscle that actually has a trigger point, or inside that trigger point, you're going to see a much higher jump, and you're going to have a lot more end plate noise than you will in a normal muscle that's relaxed most of the time. Biochemistry. Biochemistry means that we're looking at what is around that trigger point. What sort of thing is right around the trigger point chemically wise. So how Shaw did this was he took dialysis needle, he stuck it into the active trigger point, he aspirated the area and looked at the chemistry before a local twitch response. He looked at active trigger points, latent trigger points, which are trigger points that don't refer pain without being aggravated. And he looked at areas that don't have trigger points. What he found, what he was looking for was pH, bradykinase, substance P, all kinds of things that are for edema and would cause pain, and are also characteristic of decreased oxygen, hypoechoic areas. What he found after the local twitch response, okay, was an immediate change in the bradykinase, in the other properties that he was looking for. So the calcitonin gene-related peptides, the bradykinase, all of these had an immediate reduction. Now, why is this up to 15 minutes? Because nobody is going to stand having a needle being stuck in them for hours. Okay, it's too dangerous to do that. So it was up to 15 minutes with no motion, obviously. So there is a limitation in this paper, but you can see the same thing in interleukin 6, interleukin 8, with a significant reduction over 15 minutes, which gives me a time to move them and change them, and hopefully not return to that initial level. What do I find on palpation? What do I find when I look at the patient that actually touched them? Here, we have a big problem. It's unreliable, but it's the most widely used way of telling that there's a trigger point. Now, its unreliability has to do with inter-tester reliability. This paper in 2016 looks at experienced versus inexperienced inter-examiner reliability on location classification of myofascial trigger point palpation. They diagnose lateral epicondylalgia, okay? Experts and novice palpation of extensor carpi radialis brevis and extensor digitorum. Experts had 81% and agreement on extensor carpi, and 77 on extensor digitorum, and experts versus novice, 50% each. Now, the question here that it says is training. I agree and disagree. My master's thesis was in 2002, not 2016, and I looked specifically on training fourth year's novice students with an ultrasound to palpate the lumbar spine. We did not get a significant improvement in their palpation skills. And we look at, if you look at the limitation of palpation research, you will find that all you can really do is just put your hand on the patient. You can't talk to them. You can't do all kinds of other things that most of us do as physios, because that's the limitation of research. So I slightly disagree that it's just training. I think we have to look more broadly at it. And I will go back to something that's not evidence-based. All of us have been in a situation where the patient says to us, wow, how did you know that that's where it hurts? Well, I listened to you. I looked at you move. I looked at a lot of other things, and I talked to you. And then I looked at the way you reacted when I touched you. It wasn't just like, okay, this is where it's going to hurt. So there's a combination of a lot of things we do. So that's why the expert clinician picks this up faster, okay? But I think that if we talk to the patients a lot, then we're going to be very similar in what we're actually finding. So at this point, before we go on, I'd like to see if there are any questions at all at this point. And where's the chat box? Here, chat box. I haven't seen any questions. Since we're such a small group, you can, if you have any questions, you can unlock your microphone and we can go from there. If not, I'll continue with the lecture. So any questions at all? Okay. So once we have looked at why the trigger point has set up, why it's there, how do we find it, and so on, let's look at some effects and how trigger point affects our patients. So this paper by Gerber in 2015 looked at how dry needling alters trigger points in the upper trapezius neck pain patient range of motion. And the trial showed that a combination of dry needling with range of motion, there was a significant decrease in pain and a significant improvement in range of motion that was statistically significant to the group that did not get the dry needling. If we look at this paper in 2018, okay, we look at the efficacy of dry needling as with manual therapy in patients with chronic mechanical neck pain. It's an RCT, and you have two groups. You have dry needling and manual therapy groups, and then you have a sham dry needling and manual therapy group. The dry needling and manual therapy group had improved range of motion. They had significant decrease in what's called pressure pain threshold. That's how much when pain starts by putting pressure on them. And they had a statistically significant decrease in their NDIs, neck disability index, as opposed to the other group, the control group. So you can see that on the left in the charts. What's important to show here, and to add again with the limitation of research, I'm an Australian trained manual therapist as well. This RCT, if we went for a long run, would have a problem, because without patients getting some sort of exercise, sort of self-help, even if it's just self-education, hey, you can move your range of motion, use this new range to drive, reverse, do all those things, even if it's that basic thing. Without that, looking just at manual therapy and just on that, that's really not enough therapy. It's inappropriate therapy when it stands on its own. If we look at the upper trapezius in this paper in 2015, they looked at the changes with the local twitch response under ultrasound. And what they showed was statistically significant decrease in stiffness. It's measured in ultrasound by the size and the cross-sectional area of the muscle, and a reduction again of PPT. It wasn't statistically significant here. I might have some thoughts on why it might not be statistically significant. Again, they're looking at something very academic. The look here is not at getting the patient to feel better and move better. So there is, again, some limitation in these papers. But when you look at what happens at repeated needling, and you look at the blood flow and look at the hypoechoic area on the left, as opposed to what happens on the right, you see an improvement in the tissue patency and how the tissue is actually functioning and living, and that's a positive thing. There's a problem with this paper, again, repetitivity. It's an expensive thing. Most of our patients won't be able to afford to do this sort of treatment again and again. This paper is very interesting in that it's a double-blinded knee arthroscopy paper and total knee arthroplasty paper. What they did here was they stuck needles in patients having total knee replacements after the patient was actually anesthetized by the doctor. So the anesthesiast anesthetized the patient, then somebody came in and needled their femur close to the joint, and what you can see, and the other group, the control group, were not needles. So they are blinded. The patients are blinded because they're already asleep. The doctor is blinded because he was not in the room to know who is who, and the therapist is blinded. What you see in baseline is not a huge change, but what you can see in VAS, and this is really important, is that 1 month, 3 months, and 6 months later, there's significant improvement in the group that is been needled. Now, what does this mean? If we look here in this paper at function, and we look at the patient getting stronger and being able to do something better, faster, this paper is very, very good, because although it's looking at pain and analgesia and how much medication they're taking, okay, reduced need, decreased pain. If the patient has decreased pain, the patient will move faster, better, stronger, okay, on their own. And if they do faster, better, stronger, their recovery is going to be better. And if we look in the ICF way, if we look at their basic function, they're going to be able to go to the toilet better, they're going to be able to go upstairs better, they're going to function better. So their knee disability index is going to improve over time as well. Again, if we look at lower trapezius in this paper, and we look at the efficacy of needling lower trapezius with mechanical neck pain, if you think of lower trapezius as a muscle that is agonist to upper trapezius and has to hold and assist the neck and the shoulder elevation, when we get neck pain, when we overuse upper trapezius, we're going to do the same thing with lower trapezius. When they needle this patient, it's reduced their pain significantly at 1 week and at 1 month, statistically significant. Their neck pain questionnaire was 50% better than controls, 5.6% better than controls. And it was very important to needle the trigger point, okay? Because what they looked at is that they did needle the control group, but they needled them 50 millimeters away from the trigger point. So being in the right place is important by this paper, okay? When we look at shoulders, in 2017, there's a paper looking at the contribution of dry needling to individualized physical therapy treatment in the shoulder in a randomized controlled trial. It showed no benefit over individual care. I agree with the paper 100% that there was no benefit. I completely disagree with what they needled. They needled not individually, okay? They needled the same thing on all of the patients. So in the control group, they gave them individualized physical therapy, and they strengthened them and gave them shoulder symptom modification exercise that was appropriate to that particular patient. But in the dry needling group that was done dry needling and specific, they chose to needle the same thing with everybody. And that just doesn't make sense. The needle supra and infraspinatus on everybody, if that's not necessary, it doesn't make sense. So I don't love that paper because of that. If we look at the 2016 paper, dry needling of infraspinatus, latent and active myofascial trigger points in older adults with non-specific shoulder pain, okay? Reduced pain intensity, statistically significant, and there's an increase in pressure pain threshold. If we do both of those and give the exercises, the patient will work better with us. If we look at the ankle and what can happen with the ankle with dry needling, trigger point dry needling and proprioceptive exercise for chronic ankle instability. When I was a student, I was taught that an ankle sprain was what every physio could make better, because within 1 or 2 weeks, the patient will usually feel better in most situations. But somebody who's slightly active or moderately active, 75% of them, according to a paper in JOSPT, will become chronic ankle sprainers or instability. Part of the major problem there is lack of rehabilitation. If we have rehabilitated them, given them the exercises, and if they had done the exercises because they're not having pain, they might not become these chronic ankle instabilities. And what they looked at here was dry needling with exercise. I think the exercise is more important here, but dry needling had greater improvement in function and greater reduction of pain at 1 month than the group that had just the exercise. They were needling pronatus longus and brevis, which are the only 2 muscles that do eversion, which will substantially improve our proprioception in these patients. If we look here at chronic low back pain, this paper looked at explained pain, neuroscience education, in addition to trigger point dry needling and management. What they found that pain, disability, kinesiophobia, fear of motion, widespread pressure sensitivity in patients with mechanical low back pain. These are the patients who we saw. Trigger points and trigger points with neuroeducation, explained pain. Both groups experienced similar decrease in pain. Their Oswestry disability and their Roland Morris questionnaire had similar changes, similar pressure pain threshold changes for these patients. But the kinesiophobia, the group with the trigger point dry needling and neuroscience education, had a greater reduction in kinesiophobia. I think that this is very, very important. Obviously, the Oswestry and the Roland Morris are objective questionnaires of function. But if the patient is moving better, they're less fearful of motion, and we get them to do something more specific, then over time, hopefully their Oswestry will get better as well. But we do need to merge this and look specifically at the patient, because if the patient is kinesiophobic, we need to push them and ask them to do more and more, especially. And if the patient is not kinesiophobic, then get them to move. Get them to do what they want to do. Get them to do something aerobic, and they're going to feel better. The dry needling just allows you to have a window of opportunity to do something. Gonzalez looked at trigger point dry needling for the TMJ, deep dry needling trigger points in masseter and the temporomandibular muscles. It compared dry needling and lateral pterygoid muscles with medication and without medication. Both groups improved with pain at rest and when chewing. The dry needling group improved more than the control group, okay, in day 28 and day 7. The dry needling had twice as much effect size on the TMJ function as the groups that did not get the dry needling. Okay, so, and the people who were dry needled had significant, they're reported, 43% of them reported improvement, while only 13% reported improvement when they were not dry needled. Is 43% perfect? Far from it. It really is not perfect. It's statistically significantly better than the other group. Is that enough? No, we need to continue digging on this patient and see what else we can do for them. This paper in 2020, the effect of dry needling on lower limb dysfunction post-stroke survivors. There are not a lot of papers, if any, on neurological patients. But if we look at this particular paper that is looking at objective findings of looking at timed up and grow, looking at single leg stance, 10-meter walk, looking at Barthel index, looking at all these things, you can see that the dry needling group had significant changes that were significant improvement that allowed them to move better. Now, there's several key things here that are very important. And the take home is that if we can, timed up and go is statistically significantly faster. And the 10-meter walk is better. Then, and all of these findings are better. What we get is increased safety because the chance that the patient is fall is going to decrease. And then we can do other balance and strengthening things. So it's a springboard to doing something else. It's not a standalone. So let's talk about the elephant in the room safety-wise, because if I stick a needle in the pec, if I stick a needle in latissimus, if I stick a needle in the neck or something like that, there's a lung there. There's lots of other things there that we need to address. The most important thing is that we need to know our anatomy. We need to know anatomy very well. There's a paper in 2011 by McCutcheon that was published in Physical Therapy Reviews. It's an open access paper. She did a narrative review and showed that if acupuncturists and dry needling in regions that are dangerous, if they do it safely by a well-trained physio or healthcare practitioner, it's very, very safe. And we talk about very few iontogenic pneumothoraxes. The key here is safety. And that's true in everything we do, but this is actually breaking the skin. So in summary, trigger points, dry needling has a solid basic science evidence in ultrasound, in EMG, in biochemistry, maybe in palpation. There's good recent evidence for the efficacy of using dry needling with other treatments. And this is a very short treatment. It takes several minutes of your treatment. It doesn't take 7 minutes of ultrasound. It doesn't take 3 minutes of laser. It doesn't take something like that. So think if you have a 30-minute treatment, 3 minutes of laser is 10%. 7 minutes of ultrasound, 5 minutes of ultrasound, you're getting up there in the treatments. This is very, very quick and gives you a lot of bang for your buck. You're able to do other things, to do other techniques. And it can be done very safely with proper training. Now here, there'll be some question and answer time. And if you have any questions, I'd be happy to tell you about them, and also to tell you about your local hosts, because theoretically, once things start opening up, we had a course planned for Prague on the 12th. We had a course planned for Holland for next week. For this week, actually, I was supposed to start teaching in Holland on the 2nd, and we have one coming up in Bulgaria. All of them will be coming up. They will all come when COVID will allow us to travel safely and easily. They will all be following local protocols, obviously, and I hope to see you on some of these courses. So you can contact me. The email is going to be there, and some of your local hosts, and on our website on dryneedling.co.za, and you'll be able to see any of your local courses, and the hosts will be welcome. Once you contact me, I will pass you on to the local hosts in each one of these places. Okay, so I would suggest that all of you, if you have questions, unmute yourself at this point. Okay, and why can I not okay, unmute yourself. And Evelina seems to have a question.
No, I don't have a question. I want to share my experience. I used dry needling for a year and a half. I work with patients with neck pain, and here in Bulgaria, my patients are going to a doctor, and he's making some um, rentgen or a scan or something like that, and he's saying, "Ah, you're healthy. You don't have anything on the scan," and uh, but people are still having their pain. And I use dry needling, and it's very, very effective. I don't have a patient which didn't have any improvement by dry needling. And this is a very good way to improve our skills, and we could be uh, better therapists using this method.
Thank you. One of the things that I really harp around our course in particular is, as rehab practitioners, we have the privilege, Evelina was just talking about the doctors looking at biology, we have the privilege of time and repetition and seeing these patients so they can function and do what they want to do. Okay, so needling is a small part of being a physiotherapist. I've been a physiotherapist for 27 years, and I've been involved in needling for 11. Okay, so I have lots of other things in my treatment, but when there's a muscle, when there's a trigger point problem, when there are a muscle involvement, like in some of those examples that we gave, including a simple ankle sprain, then I will do dry needling. Are all of my ankle sprainer patients going to get needled? No. Are chronic ankle sprainers going to get needled? Probably. Okay, but it's not across the board, and it is a very effective technique. And yes, I obviously use it quite a bit. Big difference between athletic patients and my older non-athletic patients who might have osteoarthritic changes, and then maybe I would use it less. Are there any other questions? Any comments? Okay. The people, can we open up the chat? Where is the chat? Chat. Open up the chat. So we are only 8 people here, including me. Are most of you guys, can you write for a second in the chat where you're from? I'm going to unshare this for a second. Go back to the white screen.